as are the auditory flashbacks. They're frequently often the voice of the abuser. Depersonalization and derealization are also seen in PTSD related to dissociation, are also potentially confusing features. So, beginning to look at the prevalence of psychotic disorders in ASD, we looked at the prevalence of mental illness in intellectual disability. Hughes, McCormick, and his group looked at this in 2017 to describe the prevalence of mental illness in the population with intellectual disabilities compared with those without intellectual disabilities. So they studied a 94% completed Scotland census in 2011. There was data on intellectual disabilities, mental health, and general health were extracted, and the association between them was investigated. They found that over 26,000 persons, over almost 5.3 million, were diagnosed with intellectual disability, or about 0.5%. So looking at the prevalence rates in mental illness in persons with intellectual disability in comparison with the general population, we see that children with intellectual disability, about 13% will have a mental illness of some sort. In contrast with children of more typical development, the rate is 0.3%. When we look at adults with intellectual disability, nearly a quarter will have a diagnosable mental illness. Again, in contrast with more typically developed adults, we see about 5.3%. In older adults, the incidence increases further to 27%, in contrast with 4.5% of older adults in the typically developed population. Other findings from the study was that general health was substantially poorer and associated with mental health conditions. The population with intellectual disabilities were significantly more likely to have physical disabilities, blindness or partial sight loss, deafness or partial hearing loss, and autism. 21% in persons with intellectual disability versus 0.5% in the typically developed group. So let's look now at the prevalence of various mental illnesses in autism spectrum disorder. As you can see, ADHD is far more common in autism spectrum disorder, but interestingly, the incidence of anxiety disorders is quite similar. Sleep-wake disorders are also similar. There's about twice the incidence of disruptive impulse control or conduct disorders. Though I personally have a hard time giving someone with autism without the basis for robust social connections to have a conduct disorder, given that it's always reactive to another person. Depressive disorders are over twice as common. OCD, 9% versus 1.2 in the general population. The incidence of bipolar disorder is very similar, but there is about twice the incidence for any psychotic disorder in the autism spectrum disorder population at about 4%. Now, I have to say that not all the literature I found was consistent. So where there was difficulties with separating the two diagnoses in the basis for the study, I excluded those reports. So one study talked about, that I did not include, talked about the difficulty distinguishing delusions from the tightly held ideas of autism spectrum disorder. But as will find out shortly, there are clear differentiating features that help in diagnosing autism versus schizophrenia. So Sullivan and his group looked at data collected from the Avon longitudinal study of parents and children, a group of over 5,300 members. Data was provided on either the presence of autistic traits or a diagnosis of autism spectrum disorder and psychotic experiences by age 12. They found that both the diagnosis of autism spectrum disorder and the presence of autistic traits were associated with psychotic experiences. Their conclusion, these findings suggest a shared neurodevelopmental origin for autism and psychosis. Sutterloff and their group looked at this issue in adolescence, and they looked at the alleged association between autistic traits in childhood and adolescent psychotic experiences. Could this be explained by a general neuropsychiatric problem factor comprising symptoms of ADHD, tic disorder, developmental coordination disorder, and learning disorder? They completed twin analysis to examine the genetic and environmental influences on the possible associations. So they studied over 9,000 twins with data on childhood autistic traits and other neuropsychiatric problems, and follow-up data on psychotic experiences at ages 15 and/or 18 were included. Auditory hallucinations were analyzed separately from other psychotic experiences. They replicated prior research finding a significant association between autistic traits in childhood and auditory hallucinations at ages 15 and 18. However, controlling for the general neuropsychiatric problems factor, the association between autistic traits and auditory hallucinations disappeared. However, the association between general neuropsychiatric problems and auditory hallucinations persisted after controlling for autistic traits. The twin analysis revealed that the association between the general neuropsychiatric problems factor and auditory hallucinations was driven by shared genetic influences. So this study by a different Sullivan looked at the presence of schizophrenia or bipolar disorder in the first degree relatives of a person diagnosed with autism spectrum disorder. And as we know, a first degree relative is a family member who shares about 50% of their genes with a particular individual in the family. First degree relatives include parents, offspring, and siblings. They studied 3 populations: the Swedish National Patient Register, which contains all discharge diagnoses from all inpatient stays since 1973, and the outpatient psychiatric treatment since 2001. In Stockholm County, their records review looked for pervasive developmental disorder diagnoses for all youth 0 to 17 who received health services between 1984 and 2007, or over 589,000 youth. They also looked at an Israeli sample, as all Jewish persons born in Israel are required to participate in an assessment at age 17 prior to compulsory military service. This assessment determines intellectual, medical, and psychiatric eligibility for military service. Psychiatric evaluations diagnosed both ASD and schizophrenia in this population. So the presence of schizophrenia in parents was associated with an increased risk of autism spectrum disorder in a Swedish national cohort and in the Stockholm County group. Similarly, schizophrenia in a sibling was associated with an increased risk for autism spectrum disorder in the Swedish national cohort and in the Israeli conscription cohort. Bipolar disorder showed a similar pattern of associations, but of a lesser magnitude. So their conclusion was that ASD, schizophrenia, and bipolar disorder share common etiologic factors. So the cross-disorder group of the Psychiatric Genomics Consortium studied the genetic relationship between 5 psychiatric disorders. They looked at the relation between autism spectrum disorder, attention deficit hyperactivity disorder, bipolar disorder, schizophrenia, and major depressive disorder. Rather than looking at twins or a population-based study, this work focused on identifying shared single nucleotide polymorphisms, or SNAPs. As Marth stated, single nucleotide polymorphisms are the most abundant form of human genetic variation and a resource for mapping complex genetic traits. Perhaps not surprisingly, there was a high degree of genetic correlation between schizophrenia and bipolar disorder. There was a moderate degree of genetic correlation between schizophrenia and major depressive disorder, and also bipolar disorder and major depressive disorder. And somewhat surprisingly, there's a moderate degree of genetic correlation between ADHD and major depressive disorder. Perhaps most relevant to our discussion today, there is a low degree of genetic correlation between schizophrenia and autism spectrum disorder. There was a lack of genetic correlation between autism spectrum disorder and attention deficit hyperactivity disorder, and autism spectrum disorder and Crohn's disease. They look for a potential association here due to the high incidence of gastrointestinal symptoms in autism spectrum disorder. So Larson and her group looked at 75 persons, primarily men, and 71 of these persons had one of the DSM-4 psychotic disorders: an affective psychosis, bipolar disorder with psychosis or depression with psychosis, schizophrenia, or psychotic disorder not otherwise specified, which DSM-5 calls an unspecified psychotic disorder. Their comparison groups were 568 persons with psychosis and no ASD diagnosis, and 69 persons with a DSM-4 autism spectrum disorder diagnosis, including Asperger's disorder, but no psychotic disorder. So persons with autism spectrum disorder were identified using the DSM-4 criteria or the Autism Diagnostic Observation Schedule, or ADOS, or the Autism Diagnostic Interview Revised. Persons with a comorbid psychosis were identified in 2 steps: a prior diagnosis of psychotic illness or an episode that is clearly psychotic. Then the psychotic symptoms are confirmed by either the diagnostic interview for psychosis or the psychiatric assessment schedule for adults with developmental disabilities. And I think one of their conclusions is very important here. And they stated, in practice, there was little confusion between symptoms of autism spectrum disorder and of psychosis in our participants. Psychosis was, always associated with a change from a previous level of functioning and rarely involved a person's special interests or repetitive behaviors. So here's 2 good clinical points for making the differentiation between psychosis and autism spectrum disorder. Their other results were that individuals with autism spectrum disorder who also developed a comorbid psychotic illness differ significantly in their autistic phenotypic profile from individuals with autism spectrum disorder alone. The group with both ASD and psychosis showed significantly fewer lifetime stereotypic, repetitive, or restrictive interests or behaviors. The diagnostic profile for individuals with ASD and psychosis also differed in that individuals with ASD and psychosis had lower rates of schizophrenia as diagnosed by DSM-4 and higher rates of psychotic disorder not otherwise specified. They concluded the considerable diagnostic heterogeneity of psychotic illness in ASD plus psychosis argues against there being a unique form of psychotic illness linked to autism spectrum disorder. So to summarize the results, these studies have looked at persons with autism spectrum disorder and found an increased risk of schizophrenia, bipolar disorder, depression, and anxiety. Thus, it seems that major mood disorders and psychosis share risk pathways with autism spectrum disorder. As potentially diverse as having a common genetic mechanism, or because the long-term experience and stress of having autism and spectrum disorder increases the likelihood of developing mood disorders in adolescence and adulthood. And both of these elements are consistent with a stress vulnerability model of affective disorders and/or psychosis. So to summarize this portion of our presentation this morning, I included this case study looking at a child with autism spectrum disorder who was diagnosed with schizophrenia as an adolescent. There was a normal pregnancy with no report of nicotine, alcohol, or drug use. By age 3, the child was found to have significant speech language delays and echolalia, plus gross and fine motor delays. At age 5, the child was diagnosed with partial complex seizure disorder and started on Tegretol. At age 6, he was diagnosed with attention deficit hyperactivity disorder, and his IQ was found to be 67. He was referred to a psychiatric clinic at age 15 because he experienced domestic abuse by his stepfather, who did not allow him to eat at the dinner table or use the bathroom to urinate. On one occasion, he was physically abused by his stepfather, but witnessed stepfather's abuse of his mother multiple times. At age 18, he was hospitalized for hallucinations and delusions, such as seeing ghosts in his room and believing that he needed an exorcism. So what we have here is a nice description of some of the comorbid features that need to be looked at, such as the presence of a seizure disorder, and also refers to this patient's experience of trauma. And with developmental disabilities, the risk of physical, sexual, or emotional abuse is measured at anywhere between 2 to 7 times the rate that children with more typical development are abused. So the case study concluded that the line between ASD and psychosis appears to be distinct on the surface, but further studies suggest these two disorders share a commonality and a vulnerability towards each other. Careful discussion, history taking, and long-term follow-up is warranted to elicit understanding into the perceptual experience of the patient. Genetics, birth and developmental history, behavioral observations, and response to treatment may help in diagnosing and treating a person with suspected psychotic episodes and autism spectrum disorder. Now, moving on to catatonia. This is a subject that has come up with a couple of patients I've had to deal with in the last year here in my work for a major American insurance company. And these have been difficult to treat, both due to the rarity of persons comfortable in treating catatonia, but then the factor of many people being uncomfortable in treating autism as well. So in catatonia, we see catalepsy, or the passive induction of a posture held against gravity, waxy flexibility, slight or even resistance to positioning by an examiner, the tendency to return back to that previously held posture. No psychomotor activity, not actively relating to the environment. Agitation, but not influenced by external stimuli. Mutism, negativism, defined as opposing or not responding to instructions or external stimuli. Mannerisms, stereotypic behaviors, such that is repetitive, abnormally frequent, and non-goal directed movements. Grimacing, echolalia seen in catatonia, and echopraxia as well, that is mimicking another's movements. The same set of criteria are used to diagnose catatonia across all DSM-5 diagnoses. So there's a specifier with catatonia for schizophrenia, schizoaffective disorder, schizophreniform disorder, brief psychotic disorder, and substance-induced psychotic disorder. Specifier with catatonia for current or most recent major depressive episode or manic episode is also present, as is catatonic disorder unspecified or not otherwise specified. Now, Fink and Taylor looked at catatonia in autism spectrum disorder. Criterion A, immobility, drastically decreased speech, or stupor of at least 1 day duration associated with either catalepsy, automatic obedience, or posturing. The spontaneous or active maintenance of a posture against gravity. Criterion B, in the absence of immobility, drastically decreased speech or stupor, a marked increase from baseline for at least 1 week of at least 2 of the following: slowness of movement or speech, difficulty initiating movements or speech unless prompted, freezing during actions, difficulty crossing lines, inability to cease actions, stereotypic behavior, echo phenomenon, automatic imitative actions such as echolalia, echopraxia, again, imitating movements, and echographia, imitating writing. Ambitendency, which is a tendency to contradictory behavior arising from conflicting impulses, and catalepsy, automatic obedience, and posturing. Now, an expert on catatonia and ASD made the 10 commandments, though I can't say that I agree necessarily with all of them. He stated catatonia is diagnosable syndrome in autism. Patients with ASD are prone to develop catatonia due to current medical and psychological impairments, concurrent medical and psychological impairments. There's a very specific treatment of catatonia in ASD and consists of benzodiazepines and ECT. And this is where I have some disagreement with his conclusions. Some severe forms of repetitive self-injurious behavior are best conceptualized as catatonic stereotypy, with body injury for which benzodiazepines, electroconvulsive therapy, and maintenance ECT are indicated. Do not use antipsychotics in the active phase of catatonia before benzodiazepines or ECT is started in order to avoid malignant catatonia and neuroleptic syndrome. Lorazepam initial administration of 1 to 2 milligrams by mouth or injection, followed by increased doses up to 20 to 30 milligrams per day, depending on the level of response and the presence of side effects or sedation, or use of Ambien or zolpidem, using either one as a challenge test can verify the catatonia diagnosis. These high doses of lorazepam, up to 20 to 30 milligrams per day, may be necessary for full symptom resolution, and surprisingly are well tolerated without sedation by some patients. Bilateral electroconvulsive therapy is the definitive treatment for catatonia in autism spectrum disorder when lorazepam does not bring about swift or sufficient relief, or when fever and autonomic dysfunction arise. Maintenance ECT is a safe treatment option that is sometimes crucial to avoid relapse. And catatonia provides a window into the mechanism of autism and vice versa. Though I don't think it's this frequent, he states catatonia is autism spectrum disorder has increasingly been recognized at a rate of 4 to 17% in adults and adolescents with autism spectrum disorder. Catatonia can be characterized by repetitive movements, mutism, posturing, and frantic agitation. These signs are also frequent in autism, yet usually do not amount to a diagnosis of catatonia unless there is a sharp and sustained increase of these symptoms lasting days or weeks. So again, I think this is a crucial differentiating point between autism and catatonia, in that there's a sharp and sustained increase in these symptoms lasting days or weeks. De Jong and his group looked at intervention used to treat catatonia in persons with ASD. They reviewed 11 papers with a total of 12 cases. So that's a very small number. Each patient received at least one course of ECT ranging from 7 to 29 sessions, typically 2 to 3 per week. Almost all cases reported a marked or dramatic improvement with electroconvulsive therapy. In several cases, the ECT was described as life-saving. Several case studies reported rapid recurrence of symptoms when ECT was suspended, and the majority of these studies made no reference to any adverse effects of treatment. Though as we're aware, the incidence of memory loss is perhaps the most common side effect in ECT. They also looked at pharmacologic interventions. Lorazepam was used in 4 cases, dosages ranging from 1 to 8 milligrams per day. It was either used alone or in combination with clozapine, up to 400 milligrams per day. Typical antipsychotics, the oldies such as Haldol or Thorazine, or atypical antipsychotics. Haldol was used in 2 cases ranging from 2 to 14 milligrams per day. Other medicines studied were nortriptyline in 1 case, romazepine in 1 case, Luvox in 1 case, and an unspecified medication in another. Outcomes of this pharmacologic intervention group suggested improvement in all cases, though there was, in most circumstances, residual symptoms. Behavioral descriptions of improvement were also reported, such as increased speech or return to work or school. In the majority of cases, medication was continued indefinitely or gradually tapered as symptoms improved. The outcomes, where they were mentioned, 4 studies showed no recurrence of symptoms, and 3 studies reported either fluctuating symptoms or further catatonic episodes. Behavioral interventions were also described. The duration of catatonic symptoms in this group ranged from 12 months to 3 years. They described, Shaw and Wing described a behavioral intervention which involved psychoeducation for caregivers, reducing stress, encouraging engagement in activities, and use of prompting and maintaining structure and routine. After 9 months, the symptoms were judged to be improved, but with continuing mobility problems, including slowness, freezing, and poor coordination. Though this study indicated that the parents of the patient were noted to be seeking other treatments, for which I'm not surprised, given the length of treatment and the continuing catatonic symptoms. Now, sensory treatment was used in 3 cases called packing therapy, described as promoting sensory integration, and involved wrapping patients in damp sheets while inviting them to express their feelings, sensations in fantasies. In all cases, catatonic symptoms were reduced but not absent. So overall, DeJong and his group concluded that ECT and high-dose lorazepam may have an acute effect on catatonic symptoms in autism spectrum disorder. Often attempts to taper ECT or decrease medication dosages appeared to result in increased symptoms. Behavioral treatment may be more effective in patients who are not severely medically compromised. They also concluded that catatonia is believed to become harder to treat if symptoms become chronic, and that the current literature emphasizes the need for early and effective treatment. The cases with the best outcomes involved younger patients treated soon after the diagnosis of catatonia. Wachtel and his group looked at 3 patients who were placed on maintenance ECT for their autistic catatonia. All 3 of the patients benefited acutely from ECT. The reappearance of catatonic symptoms continued to be treatable with maintenance ECT without side effect. The current treatment of catatonia includes, again, lorazepam in doses as high as 18 to 24 milligrams per day with titration based on patient response, and bilateral ECT when there's no response to lorazepam or when catatonia symptoms are severe. So that completes our review of psychosis and catatonia in autism spectrum disorder. And I thought I'd share a picture with you of one of my cats, Tasha, instead of the usual picture of my dog. So I'm happy to answer any questions you might have. And I have included at the end of the presentation, and I will send the slide deck on to the leaders of this conference after my presentation. Any questions?
Hi, Bob.
Hi.
Hi. Do you hear us?
I can.
Hi.
It's nice to see all of you again. Well, I'm hoping that in 2022 we'll be able to meet in
we would
person.
like also.
Go ahead.
Как делать низ?
Okay. Hi, Bob.
Hi.
Yes, so thank you very much for your wonderful talk. We are very happy to see you with us, despite the pandemic, despite the heat in Arizona, and all the distance. So we are very grateful for your wonderful job. The presentation was very interesting. And we had a couple of questions. So first of all, we wanted to go back to comorbidity between autism spectrum disorder and schizophrenia. And the question is more about so-called like attenuated psychotic syndrome. De novo criteria in DSM-5 as a development of psychosis, and how do you think, what is your opinion concerning the need of diagnosis and usefulness of this category in patients with autism spectrum disorder?
I'm not too familiar with that. It's complex because the number of cases is very small. And so I've seen activated individuals, but I don't think it lends clarity in terms of what interventions to use. So I find it to be less useful in this population.
Okay, thank you.
And hi, Bob. And one more question. You mentioned the electroconvulsive therapy is applied for children. Here in Ukraine, it's quite controversial question, and I'd like to ask you what is the target age of children usually used for electroconvulsive therapy?
I would agree that it's controversial for adolescents in the United States as well, but I've dealt with one particular case where it was recommended and carried out at a university children's hospital for a child who was either 15 or 16 years old. But again, there's a lot of controversy, and there were a lot of approvals from ethics committees and other review committees at the university center before it was allowed to go forward.
Okay, I see. And one more question. You mentioned also the use of benzodiazepines for catatonia. And I wonder, in epilepsy, we often see the effect of weaning off of the effect of benzodiazepines. Is the same for catatonia? When you use prolonged, I would say, the benzodiazepines for a long time, do you see the gradual decrease of efficacy?
The cases that I'm familiar with, I haven't seen. It's hard to tease out because usually those folks have received both treatment with lorazepam and ECT at the same time. So it's really hard to tease out the difference between the two. On the other hand, I would agree with the findings that the cases that I've been peripherally involved with, they've continued on high doses of lorazepam, and symptoms did return when they tried to taper the dosage.
I see. Thank you.
Yeah. So thank you very much again, and we hope that you will join us together like the next year in person already. So we hope that everything will stabilize, and see you soon. Thank you very much. Bye bye.
I hope too. Bye bye.
Bye bye.